Muted. The broadcast is now starting. All attendees are in listen-only mode.
All right, good afternoon. I want to welcome you to the CompleteRx Thinking Pharmacy Knowledge Series. Today's webinar will focus on recent changes to the HRSA 340B drug pricing program, specifically as it relates to 340B audits and compliance. My name is Pam Andrus, and I'll serve as the moderator for this discussion. The webinar is scheduled to last approximately 30 minutes with the Q&A immediately following. All participants will be on mute, so if you have questions, please type them in and we'll answer those at the conclusion of the presentation. For more information on CompleteRx, along with upcoming webinars and events, please visit the CompleteRx.com website. I'd like to start by introducing our speaker, Mr. Ken Maxick. Mr. Maxick is the Director of Patient Safety and Pharmacy Compliance for CompleteRx. He brings over 20 years of hospital operations, management consulting, and healthcare executive experience to the firm. He's a certified master black belt in Lean Six Sigma, ISO 9001 provisional auditor, senior member of the American Society for Quality, and a fellow in the American College of Healthcare Executives. He's managed a broad spectrum of engagements throughout the U.S. in the areas of general operations improvement, pharmacy compliance, patient safety initiatives, and hospital benchmarking. Mr. Maxick has a master's in business administration from Syracuse University and a bachelor's of science in pharmacy from Albany College of Pharmacy. I'll now turn it over to Mr. Ken Maxick.
Unmuted.
Thank you, Pam. I appreciate it. I just wanted to go over a brief background for disclosure purposes for this program. This program is going to cover several topics related to the 340B program, including regulatory background, registration, and key audit findings. That's HRSA's audit findings. As a disclosure for this presentation, it does not represent guidance or agency perspective of Health Resources and Services Administration, which you'll hear me refer to as HRSA, or abbreviated on the slides as HRSA, or the Office of Pharmacy Affairs, which on the slides will be abbreviated as OPA, and is not intended to constitute legal advice. The items discussed in this presentation are representative of what CompleteRx has seen in the field related to the topic of 340B. And what I'd like to do to start us off before we go through the objectives is I'd like to take a quick polling question to see who we have out in the audience and what experience you have with the 340B program. So as you're filling out the questions to the polling question, I'll go through the objectives. The presentation today is to accomplish a few goals. The first is for those that are new to the 340B program to provide a brief background on the application process, and for those that are both new and experienced with the program to show what some of the risk points have been for covered entities. And I'll just give you a couple more seconds to finish filling out the poll. And I will close the poll out then at this point in time. And as you can see from our results, we have almost half the audience as part of a disproportionate share hospital, and almost 25% is not currently enrolled in the program. So I hope that for those that are enrolled and for those that are planning to enroll, there will be something in this program for everyone that's involved. Going into the 340B program overview, let's provide a legislative overview of the program. It was created under Section 602 of Public Health Law, which is called the Veterans Healthcare Act of '92. So as you can see, the regulations have been in effect for quite some time. And this rule enacted Section 340B of the Public Health Services Act, which is called Limitations on Prices of Drugs Purchased by Covered Entities. The Office of Pharmacy Affairs, which is within the Health Services Bureau of the Health Resources and Services Administration, administers the 340B program. The 340B program was created as a mechanism to allow eligible healthcare organizations, which are referred to in the legislation as covered entities, to stretch scarce federal resources. So while we're discussing this program and the benefits, keep in mind the answer to this question. How, as an organization, do you document what the cost savings from the 340B program are being used for? The organizations that are covered or can be eligible as a covered entity include HRSA-supported health facilities such as federally qualified health centers, Ryan White HIV and AIDS program grantees, hospitals such as children's hospitals, critical access hospitals, and disproportionate share hospitals, and then some specialized clinics such as black lung clinics and tuberculosis clinics. We'll discuss the monitoring procedures and the cost associated with implementing those procedures, but first let's take a look at why Enroll. On average, pharmaceutical savings for those medications that are included under the 340B program can be from 25 to 50%. And as we noted in the previous slide, some potential answers to the question of what are you doing with the savings can be to reduce the price of medications for select patient groups. Some facilities on their outpatient pharmacy will have a sliding copay based upon the individual's ability to pay for the medications. Others have expanded or provided new services to patients. We are seeing more facilities getting involved in post-discharge counseling from the acute care environment or delivering medications to the patient bedside in order to prevent readmissions. So, how do you enroll in the program? Well, first of all, this is changing, and HRSA just announced that a new process will be in place, making the system totally electronic. So for those of you who may be in the process of enrolling now between the July 1st and July 15th deadline date, most registrants will no longer be required to submit Medicare cost report worksheets and trial balances to the Office of Pharmacy Affairs through either email or fax. The 340B database will use the most recent data available from CMS data sources, and HRSA states, quote, the database will display to the user the hospital's cost reporting period that provided the data. So while the system's changing and the process is moving forward from a paper to an electronic format, let's just talk about what you're going to need to review. First, you need to determine your eligibility, which differs based upon the type of covered entity you are applying for. And we'll not go through every option right now, so let's just look at a couple. First, a disproportionate share hospital, children's hospital, and freestanding cancer center all need a disproportionate share rate of 11.75 to qualify as a covered entity, while rural referral centers and sole community providers need a 8% disproportionate share rate. The item that we need to keep in mind is that although the disproportionate share percentage can be the same for various covered entities, that does not mean that each entity is set up the same or needs to follow the same rules. So here's a list of what the registration periods are currently. And there are only specific times during the year that an organization can register to become a covered entity. And this slide shows the registration period and the accompanying start date for those enrolled in the program. So if you're planning to enroll during the current registration period, you now have 5 days to complete the process, as your completed application needs to be in by January 15th. So let's take an example. As long as the completed application is received by January 15th and the application is accepted, the new covered entity may begin purchasing 340B medications under the program as of April 1st. However, being it takes time to set up a new account with a wholesaler and contract with vendors for tracking purchase data as a new covered entity, you may need to go back and capture past data. Although you qualified as of April 1st, you may not have all systems in place until May 1st. And that's okay as long as you're able to capture clean, auditable data. You can then go back in time and capture the utilization to April 1st. As part of the original 340B legislation, the government was required to establish a prime vendor program. This contract has been awarded to a single organization named Apexis. And as you can see on the bottom of the screen, there is a link if you want to go to their site. The Prime Vendors Program serves its participants in three major roles: negotiating sub-340B pricing on pharmaceuticals, establishing distribution solutions and networks that improve access to affordable medications, and also providing value-added products and services. The Prime Vendor Program is a voluntary program for 340B covered entities. All covered entities may participate in the Prime Vendor Program, including those hospitals that are prohibited from group purchasing arrangements. The Prime Vendor Program negotiates discounts for all participating entities. Let's discuss some of the regulatory requirements that a covered entity will need to comply with in order to remain a part of the 340B program. And we'll go into further detail on preceding slides about these areas. The first one we'll discuss is diversion. This is the piece that started the audit process from a general accounting audit review, which was issued in September of 2011. And that review stated that HRSA oversight of the program is inadequate to provide reasonable assurance that covered entities and manufacturers are in compliance with program requirements. And we'll go through the diversion part and also go through the auditing part later on in this program. The group purchasing organization exclusion only applies to disproportionate share hospitals, children's hospitals, and freestanding cancer hospitals. Since the beginning of the 340B program, HRSA has addressed violations of this prohibition in guidelines published in the Federal Register, stating that if a covered entity subject to this prohibition participates in a GPO, the covered entity will no longer be an eligible covered entity and not purchase covered outpatient drugs at Section 340B discount pricing. So HRSA has, in 2013, issued several clarifications, and for those of you who want to look up the full clarification, this quote is from the February 2013 that was issued by HRSA, and it refers to, of course, Section 340B, which requires the Secretary to establish a mechanism to ensure that covered entities comply with the requirement prohibiting duplicate discounts. And what HRSA has done is they've established a Medicaid exclusion file as the mechanism to prevent duplicate discounts for drugs subject to Medicaid rebates. And there's a couple of terms here we want to talk about, and the first one is carve in, and the second one is considered carve out. Covered entities must determine whether they will use 340B drugs for their Medicaid patients. That's considered carve in. Or whether they will purchase drugs for their Medicaid patients through other mechanisms. That would be considered carve out, and that's where people are usually purchasing their medications at the WAC account or WAC pricing. Covered entities are required to inform HRSA by providing their Medicaid billing number at the time they enroll in the 340B program, if they will purchase and dispense 340B drugs for their Medicaid patients. This information will be reflected on the HRSA Medicaid exclusion file, so states and manufacturers know that drugs purchased under the Medicaid billing number are not also eligible for a Medicaid rebate. And this is why it is called a duplicate discount, as if the process is not set up correctly, both the state would be receiving a rebate and the covered entity would be receiving 340B discounted medications from the manufacturer. The other clarification that also came out in February 2013 was talking about the GPO exclusion. And this applies to disproportionate share hospitals, children's hospitals, and freestanding cancer hospitals. And here is a matter that since the program started, the 340B program, HRSA addressed violations of this prohibition in guidelines published in the Federal Register, stating that if a covered entity subject to this prohibition participates in a GPO, the covered entity will no longer be eligible for 340B pricing. So what does that mean? What are the consequences? Well, if you are using your GPO account for purchasing covered outpatient medications, then you can be required to refund the manufacturers the 340B discount. So if we're looking at it and you've been a covered entity for a year or possibly 2 years, you may have to go back through all of your purchase records by manufacturer and individually calculate what you owe each manufacturer back in time. So this is one to keep in mind to make sure you are in compliance with for sure. Okay, next we're going to talk about eligible patients and also the auditability of records. And an individual is a patient of a 340B covered entity only if the covered entity has established a relationship with the individual such that the covered entity maintains records of the individual's health care and the individual receives healthcare services from a healthcare professional who is either employed by the covered entity or provides healthcare under contractual or other arrangements such that the responsibility for the care provided remains with the covered entity. So, for example, if you have a primary care provider who is on your staff, who is employed by the hospital, who is seeing a patient in one of the hospital areas that is covered under the 340B program as part of the covered entity, and that individual is writing outpatient medications, that's fine. You have an eligible patient who is being seen by a provider who is covered by the program. However, if that same provider now goes and asks for, say, an endocrinologist to do a consult, in order for the endocrinology medications to still be covered, the care of the patient needs to remain with the primary care provider that is a part of the organization. Now, of course, if the consultant, the endocrinologist in this case, was also an employed or contractual arrangement with the facility, then you're still within compliance of the program. And in the past, there was posted on the HRSA website a frequently asked question that stated that an individual will not be considered a patient of the covered entity if the only healthcare service received by the individual from the covered entity is the dispensing of a drug or drugs for subsequent self-administration or administration in the home setting. This post has since been removed from the HRSA website, and it also shows how the 340B program is changing. So you need to continuously monitor what HRSA is posting and what is also being posted by the Prime Vendor program, because as I've noticed over time, things get added and things get taken down. So in order to keep up with everything, you have to be mindful of what's happening. So let's move on to the annual recertification process. And this is what will be filled out by the organization's authorizing official. And it's required annually in order for you to continue to participate in the 340B program. The next recertifying date is from August 6th through September 10th. And you need to be able to recertify in order to be eligible for the program. So what is the authorizing official saying? Well, they're saying that all information listed on the 340B program database is correct. And as we get to the audits later on, you'll see that there are several cases where that data was not correct. They're also attesting that the covered entity meets all 340B program eligibility requirements. The covered entity complies with all requirements and restrictions of the 340B program. The covered entity maintains auditable records demonstrating compliance. The covered entity has systems and mechanisms in place to reasonably ensure ongoing compliance with the requirements of the program. And if the covered entity uses a contract pharmacy service, the contract pharmacy arrangement is being performed in accordance with the Office of Pharmacy Affairs requirements. So remember, if you are a covered entity and you do decide to have a contract pharmacy arrangement either with a single pharmacy or with multiple pharmacies, you have to remember that as the covered entity, you're responsible for making sure that the contract pharmacy is in compliance. So if you need to go out and do audits to make sure they are in compliance, then that's what you need to do, and you need to monitor their records. Okay, some of the components of the 340B program that you're going to want to have in place is, first of all, we'll want to start with getting an application process for those 25% of you that are not part of the covered entities yet. So this way, when you go online, you will have all the information you need in your hands before the process starts. You'll then need to go through the application process, which, as we said, if you're doing it for this application process, you need to have completed by July 15th. Once you receive your notice back from OPA that you have been accepted into the program, then you'll need to write policies and procedures for multiple things, including audit procedures, how you're going to be ordering medications, how you're going to maintain auditable records, what areas are included, and you should also develop, at the very least, an annual report to send to the authorizing individual to show that you are in compliance with all the aspects of the program, so that when that individual is doing an attestation stating that you have made every reasonable effort to be in control of the program, you have that documentation to say that yes, you have. And for more information on the application process, here is the 340B registration PDF that you could download, which goes through more of the application process from HRSA. But one of the questions I want to answer here right now is, what drugs are included under the 340B drug pricing program? And here the definition of a 340B covered drug, which is listed on the OPA website, is an FDA-approved prescription drug, an over-the-counter drug that is written on a prescription, and a biological product that can be dispensed only by a prescription other than a vaccine, or FDA-approved insulin. Medical, surgical supplies such as syringes are not covered drugs. However, manufacturers may voluntarily give clinics a discounted price. And with that being our background to the legislation, we will now enter the world of HRSA audits, which I'm sure everybody is well aware of. So how did HRSA begin the auditing process? Well, I started off by saying that there was a general accounting office noted that HRSA was not having adequate oversight of the program. And while HRSA has conducted audits of covered entities for program compliance, in the past, those were focused on audits for suspected violations. And in the past, if you saw that HRSA had done an audit, you knew it was usually probably a pretty egregious outcome. However, beginning back in January 2012, HRSA has begun to conduct random audits. And in 2012, they had initially set their target to be 6 hospitals per month. So they would have expected there to be roughly 72 audits conducted in 2012. Then we moved to 2013, and during 2013, their goal was they wanted to hit 400 audits were expected to be done. Now, they did announce that due to the sequester, that many audits would not be done, and they did actually conduct 50 covered entity audits in 2012. So roughly, from their initial numbers, we should have had about 450 audits conducted from January 2012 through December of 2013. So what might an audit schedule look like? And usually this is set up as a 2-day audit, and you will receive an advanced audit request, which will ask you for all of your purchase data and all of your utilization data for probably a 6-month period. They say the audit on site takes 2 days to occur. However, I have heard in some cases that it takes less time and you can actually get them out the door within a day. Now, there has been a change to the audit program, which recently went into effect, that HRSA will no longer be giving a preliminary finding at the end of the audit. So you'll just get the one final report at the end after they have crunched all of the data. And within the audits, they've basically broken it down into 4 compliance risk areas. And these are the definitions that I had given you before, but we'll go over them briefly again. And they relate to duplicate discounts, drug diversion, group purchasing organizations exclusion or not being in compliance with that, and then issues related to contract pharmacies. Now, remember, I told you that there were going to be approximately 450 audits that they had done between January 2012 and December 2013. Well, here you could see, as of the last time we put the slide together, which was May 8th, there was a total of 64 audits posted on the HRSA website. So 64 out of what they said was an original 450. And out of those, 55% had findings and 41% had sanctions pending for the organization. Sanctions were not listed yet on the database. And the HRSA audit findings, as I said, there were 64 audits had been posted to the website. Of those, there were a total of 52 findings at 35 organizations. So, as you could tell, several organizations have been subjected to multiple findings. So let's go through those categories of findings and what are some of the things that they saw. First, we'll start with drug diversion. This is the 340B medication dispensed to an inpatient, or a 340B drug dispensed not supported by a medical record dispensed to a non-patient. A 340B medication dispensed for prescriptions written at an ineligible site. 340B medication dispensed to non-patients at contract pharmacy. Drugs dispensed for prescriptions written at ineligible sites by an ineligible provider. Now remember when I was talking about making sure that your database is correct and that when the authorizing official does either their initial application or their recertification to make sure the database is correct? Well, as you can see here, that there's almost 27% of the findings were related to the data in the database being incorrect. And some of the reasons were that the entity utilizing contract pharmacies were not listed on the database. There was an incorrect primary contact information, incorrect authorizing official, or incorrect entries for a primary office location and contact information. There was a closed outpatient facility that remained registered, an incorrect name listed for an outpatient facility, a pharmacy incorrectly registered as a child site, an entity sending medications to a pharmacy not listed on the database, an outpatient facility of the entity not listed on the database, a parent location listed on the 340B database was closed. Think about that one. The main site was already closed and was still listed on the database. No contract in place for a contract pharmacy, and the contract pharmacy listed but had terminated the contract. So those are several of the areas to look at when you're either registering or going through the recertification to see that what you're doing is correct and that the data that's you're listing is correct. Because remember, as the authorizing official, you're the one that's responsible for all the information in the database. Now let's talk a little bit about the last area that we found, which was 28%, which relates to duplicate discounts. Here we're talking about billing Medicaid contrary to information in the exclusion file, the 340B medication dispensed to Medicaid patients by a contract pharmacy, absent an arrangement to prevent duplicate discounts, claims submitted without state-required NPI numbers, Medicaid claims incorrectly coded when provided to the state, claims submitted without required UD modifiers, and Medicaid provider number was incorrect on the Medicaid exclusion file. So those are the most common findings that are listed on their database. So what seems to be coming up next? Well, we have been hearing about the so-called mega rule for a couple of years now, and this seems to be making its way through the legislative process and is anticipated to be out for public comments sometime in either July or August. Now, while what is contained in this regulation has not been reported by HRSA, several items may be up for clarification, which are very important. The first one being the definition of a patient. And of course, how the definition of a patient changes has a direct impact on who is eligible to receive medications. The next area that I think will be talked about is the multiple contract pharmacy service model. As you look at the expansion of the 340B program over the past several years, one of the major areas for expansion has been in the area of contract pharmacy. So I think if they're going to try and do anything to clamp down on the program, it will be in the contract pharmacy module. So this regulation is certainly going to have far-reaching impact on the 340B program and who and how the program will be enacted. So with that being said, I will turn it back over to Pam.
Muted.
Okay, thank you, Ken. We really appreciate it. Before Ken starts answering questions, we want to thank all of you for your participation today. The PowerPoint presentation will be emailed out to all attendees. The webinar with audio will be uploaded to the Knowledge Series section of the CompleteRx website, where you can download it at your convenience. If there are any hospital-specific questions you'd like Ken to address one-on-one, you're welcome to email him directly at the email address listed on the screen. So we've got some questions for Ken. We'll get started with our first question. It is, okay, Ken, you stated that different covered entities have different requirements. What are they?
Unmuted.
Okay, well, as I said, even though there are certain facilities that have the same disproportionate share percentage that's required. So, for example, disproportionate share hospitals, children's hospitals, and freestanding cancer centers are all required to have the same disproportionate share percentage. Yet, even though they all have to comply with the GPO exclusion, only freestanding cancer centers also have to comply with the orphan drug requirements. So, as you can see, even though the disproportionate share is the same, doesn't mean your requirements are the same. Now, you can move over and say, you know, a disproportionate share hospital has to comply with the GPO exclusion, and a critical access hospital does not have to comply with the GPO exclusion, yet a disproportionate share hospital does not have to comply with the orphan drug exclusion, where a critical access hospital does have to comply. So what I'm saying is, even though you're a covered entity, not all covered entities have the same rules to follow.
Muted.
Okay, next question. Can an off-site outpatient facility or facilities of the hospital use a GPO for covered outpatient drugs?
Unmuted.
Okay, there has actually been a clarification on this, and the answer is yes, they can under certain circumstances. Okay, first of all, they have to be located off-site from the parent organization, so they have to have a physical separate address, and they cannot be registered on the OPA 340B database as participating in the 340B program, and they need to purchase their medications through a separate pharmacy wholesaler account than the 340B participating parent. So if you're talking about a disproportionate share hospital and say a outpatient infusion center for some reason, you'd have one account for the disproportionate share hospital and a totally separate account for the outpatient infusion. And you also have to keep in mind that the hospital needs to maintain records so that they could demonstrate that the covered outpatient drugs purchased through the GPO at your off-sites are not utilized or transferred to the parent hospital, or for that matter, any other facilities registered on the OPA 340B database.
Muted.
Okay, and our final question, do I need to register each off-site location as a child site?
Unmuted.
Okay, that's actually somewhat related to the previous question, and only hospital outpatient facilities that appear as reimbursable outpatient cost centers on the hospital's most recently filed Medicare cost report are eligible to be listed and participate in the 340B program. HRSA and the Office of Pharmacy Affairs requires each hospital to register all of its off-site outpatient facilities where 340B drugs are purchased and are provided to patients of that facility. So if you meet the first piece and your outpatient facility is filed on the Medicare cost report, and unlike the previous situation where you do want to have to purchase 340B medication, then each location has to have itself registered, and if there's multiple locations inside one child site, those each have to be registered.
Muted.
Okay, and then Ken, can you please give us the definition of an orphan drug?
Unmuted.
The definition of orphan drug is what is listed by the FDA as being an orphan medication. So there are several drugs, and an orphan drug is one that has been listed for a specific rare disease. And because of that, they have received that specific designation as an orphan drug. Now, the clarification that just recently came out is for those organizations that do have to go by the orphan drug exclusion. For those of you who have been following, this was being challenged. The judge actually sided with the plaintiff in the case, and then the HRSA came out and said that their exclusion still does apply. So what they're now saying is if you have to comply with the orphan drug exclusion and you are using the medication for the rare disease for which it received orphan drug exclusion, then you cannot purchase that on the 340B account or at 340B price. However, if you are using that medication for something other than the rare disease that it received the orphan drug designation, then you can purchase that medication at the 340B price. So as you could tell, you would have to keep very good records to show what the purpose of the medication was and the indication for use in the patient. And you also have to, when you register or certify, make sure that you set up your initial registration that will allow you to separate orphan drug use from non-orphan drug use.
Muted.
Okay, next question. We have been eligible for 340B programs since July 1st, but our software solution will not be live for at least 2 months. What records and information for each patient do you recommend keeping while waiting for the software solution to begin?
Unmuted.
In order to get the software solution to work, you're going to need to set up your electronic data feeds, which is going to have to capture all of the information that is required to maintain an auditable record. So you'll need to know the physician, of course, the patient, where the patient was seen, what medication was given, what setting the patient was in at the time that the medication was given. All of that will need to be done. And then certainly before you go live, if you were, say you're valid as of July 1st, as I think was in the question, you're going to want to make sure and actually do an audit of the records and make sure that data is clean so that when you load that data into your third-party vendor software, it is calculating the correct buckets, if you will. So for example, if somebody has to comply with the GPO exclusion, you'll wind up with 3 buckets: your WAC account bucket, your GPO bucket, and your 340B bucket. So the first step is, once you get the utilization file in place and make sure that the data is coming across correctly, you then want to make sure that your split billing software is putting the medications into the correct buckets.
Muted.
Okay, that was our final question. Again, thank everyone for your participation today. If you have any additional questions, please don't hesitate to email Ken directly at kmaxick@completerx.com. Thank you and have a wonderful afternoon.
Unmuted.